So there is slight change in the program. We will start virtual session first, and after that we will continue with this routine session. May I invite Chairperson Dr. H.R. Zunjunwala sir to be chairperson? Yeah. Dr. Bari sir, please sir, as a chairperson, please. Yeah, for virtual session. We are starting virtual session. Dr. Manish Dhawan. Dr. Arya Agarwal sir. Dr. Arya Agarwal sir. So now we are starting our first talk by Dr. Peter Thaler on limb lengthening, deformity correction and reconstruction of large bone defects using IM nails. Session 5. Yes, sir. Virtual session. Online.
Can you see my first slide? Okay, thank you. Dear President Dr. Rajat Agarwal, dear committee of the Asamicon 2024, dear fellow presenters all over the world in this session, and finally and most important, dear participants. I feel highly honored by this invitation to India. My name is Peter Thaler. I'm involved in limb lengthening and deformity correction since more than 3 decades at the LMU, at the Ludwig Maximilians University in Munich, and since 3 years additionally at the Bethel Hospital in Berlin. 3D surgery is the surgery of bony defects, deformities, and discrepancies at length. And 15 years ago, this started as a joke, the 3D surgery, and now it became a kind of brand, and we have friends and fellows all around the world. You may realize I unfortunately caught a cold the day before yesterday, and I hope this won't affect this session. At least I'm not afraid to cause transmission online of my infection. And I have no disclosures. These are my disclosures related to this presentation. I was asked to talk about nailing in deformity correction and limb lengthening and defect reconstruction. And this simple slide, simplified figure, should show that the nail, the intramedullary nail, is in the center of the forces, and that's why we love nailing so much, because we have, to my concern, the highest stability we can get. Gerhard Küntscher is said to be the inventor of intramedullary nailing, and in his tradition, the Küntscher Society is inviting to international meetings every year. This year, we are honored to be part of the Asamicon meeting in Mumbai, and I hope to see you all there in August in Mumbai. This is a first case. A young lady, as a child, she had several treatments of external fixation because of proximal focal femoral deficiencies, and she had a leg length discrepancy and severe deformity after all this treatment. Here you can see our analysis. The mechanical axis deviation was 67 millimeters to the lateral. The medial proximal tibial angle was 190 degrees. And This is our kind of analysis and planning. We call it endpoint first planning. It's a quite simple method to do deformity plannings. As first we create the new mechanical axis. And if you correct the femur only, the new mechanical axis is defined by the tibia. If you correct the tibia only, the new mechanical axis is defined by the femur. And for a bifocal deformity like this, the new mechanical axis is defined by the joint line and an angle to the joint line of 90 to 85 degrees. And so you create the new mechanical axis, and then you draw your endpoint, the endpoint of lengthening. You decide on your kind of implants and osteotomies, and thus you can get a very comprehensive planning which you can take into the OR. So the problems of this patient were, just a second, to solve these problems, we planned a valgus osteotomy at the distal femur as a minimal invasive stab incision, drill bit osteotomy, a retrograde IM nailing, a torsional correction also, and a bit of lengthening by lengthening over nail. For the tibia, we planned a bifocal osteotomy, and because of the risk of damaging the peroneal nerve, we planned the distal osteotomy only in the first line, and then a gradual osteotomy, gradual varization in the next stage. And this is the course of treatment. And believe it or not, after about 2 weeks of gradual correction of the tibia, the patient had sensations and not a drop foot, a deficit lifting the first toe as a first sign of a lesion to the peroneal nerve. So we stopped it, went back, and finally after 28 days we met our goal, and then we could place the second plate from medial, and this is the final result after that correction. 6 months later, we took this photograph, and the young woman was laughing because I was asking, what about the plaster on the big toe on the left foot? And she said she was walking too much. Next case, a tibial deformity. This guy was hit by an ice hockey puck at the growth plate in childhood, and suffered from a patella baja, a genere curvatum with a consecutive hyperextension, which caused him an instability and a minor leg length discrepancy. We also tried to solve this with a nail, because with a plate we could not address the leg length discrepancy. With an external fixation we could have solved altogether, but the time of wearing the external frame would be maybe an estimated 4 to 6 months. So we decided to do a lengthening over nail and to correct this deformity by a nail. This is our endpoint first planning in both planes. You see also the lateral plane, and you might be considered if we can do this with a nail. This is intraoperative radiographs of the minimal invasive osteotomy. It's done only by a stab incision and a drill bit osteotomy and a chisel. And with we published this. We had the honor to be part of a paper in South Korea 10 years ago. And in this paper, the drill bit osteotomy is published. I'm sure you know these techniques. What I also want to show you is our technique of minimal invasive fasciotomy, because around the turn of the millennium we had some problems with compartment syndromes in minimal invasive osteotomies of the tibia, and around the turn of the millennium we started to do minimal invasive fasciotomy of the tibial anterior compartment. These are the incisions of this young man. This is the incision of the fibula. These are the locking bolts of the nail, and this is the osteotomy. This is the entry point of the nail. And we are doing a small incision, and with a special fasciotome, we are doing, since now more than 20 years, those fasciotomies of the tibial anterior compartments. Since then, we never had a problem of compartment syndromes at the tibia. This data were also published. This is the course of distraction by an external fixation, which we could remove after 25 days. And this is the final result after early consolidation. And the clinical result, maybe you can see that this photograph was taken when the hair hasn't yet regrown on his leg, so very early, good functional result after 3 months. With nails, we can also do distal tibia corrections. For example, in this case, this was a polio case. She has had lengthening of the femur and tibia, and still she had a equinus caused by the distal tibia by an anterior distal tibial angle of 92 degrees. And since we had a nail inside already, we decided to do this correction by a nail through the same approach as the lengthening nail was. Another case, post-traumatic case, which was nailed in another hospital in a valgus position. Also here we could do a reosteotomy and a deformity correction at the distal tibia by an antegrade tibial nail. Several other cases. This is an achondroplasia patient with torsional femoral and tibial deformities, especially on the right side. We planned a complex procedure, corrected the femur by a bifocal osteotomy with a retrograde nail and a trifocal osteotomy at the lower leg, also performed by a nail. And this is the late result after correction, with a nice new mechanical axis and a good consolidation and a nice clinical result after 2 years after removal of all the implants. We also do fine-tuning of nails by bending of fine-tuning of our osteotomies by bending of nails. We have, long time ago, we have designed a simple sterilizable bending press that provides a pressure of more than 3 tons, with which we can bend titanium nails up to 15 millimeters. And this is one example of those bending press nails in a tibial correction. We shouldn't bend the nail too deep because of the removal. If you would bend the nail deeper than this, you won't be able to remove the nail anymore. This is very, very important aspect. So the next slide is the final result of this patient after removal, and now the medial proximal angle is 90 degrees. In several papers, we re-evaluated our results, and this is an example of tibial and femoral osteotomies in varus deformities. The diamond is the status before the surgery. So this is, for example, a mechanical axis deviation of more than 60 millimeters, and this is where we wanted to get. The circle is the planned mechanical axis deviation, and this is not the most perfect result, but here you see some very perfect results where the crosses and the circles are quite close together. The next case is a case where I can show you most of our technical tricks and pearls. Multidimensional deformity of a young woman. She also had a trauma at the growth plate at the year of age. She has a valgus, severe leg length discrepancy, a torsional deformity, and a knee extension deficit. And here is the long-standing radiograph and the CT analysis of this torsional deformity. And this is our analysis and planning. Again, the endpoint first planning in 2 planes at that kind. We wanted to have a recurvation of the femur, a varisation and a lengthening of the femur by a retrograde lengthening nail. A very important tool in our surgery is the steel sleeves. Those steels are hammered into the bone to protect the entry point, and which allow us very minimal invasive surgeries in all our nailing procedures. This is the lateral view. This is a shunt screw to control the torsion and rotation. And here you see the steel sleeve, which is hammered deep into the bone to protect this path of recurvation. You see blocking screws to maintain the situation after inserting of the nail. And this is another tool which we use. It's an X-ray. It's our X-ray grid. It's a very thin 3 millimeter plate which is lying under the patient. And with the C-arm, we, in the beginning of the surgery, take a picture of the center of the hip, a picture of center of the tibia, of the ankle joint, and here you see the mechanical axis deviation. And this is the endpoint, the X-ray grid control after the surgery, still on site, center of the hip joint, center of the ankle joint, and here the center of the knee joint with the valgus correction in that case. Again, here the blocking screws to maintain the stabilization of the lengthening nail. This is the minimal invasive incision. We do transverse incisions because this is the lines of the split skins at the knee. We never do longitudinal incisions in our osteotomies around the knee. And here you see the shunt screws before the surgery, before the osteotomy, to simulate the torsional deformity. And finally, these shunt screws cover each other in the end of the surgery to maintain the torsional correction. This is the cause of distraction. Usually we distract with 1 millimeter per day, and this is the final result of that patient. You see the realignment and in both planes, and you see the clinical result. Some of those cases we have also published in this paper in Techniques of Orthopedics. And this is a very nice example of late results. This is after 2 years after treatment of this patient, the short form 36 questionnaire. This is the status before the surgery. This is the status after 2 years. A last case to show the potential of lengthening and bone transport nails is this complicated third grade open fracture, which was covered by plastic surgeons in first line by a huge flap, and she was sent to our hospital, and she has had an external fixator for 3 months already. So we always, instead of a pin holiday, we place an extramedullary external fixator before the nailing, and after 2 weeks we can do the nailing procedure. This is the X-rays before the surgery, and this is the planning of a bone transport. In this patient, we planned a monofocal bone transport with what we call a double docking, because we could leave this segment inside. We were hoping that this segment is vital and that we can achieve our goal with a double docking procedure. Always in the tibia, since more than 50 years, we use suprapatellar approaches because they are much more precise and there is good evidence that there is no risk for the femoropatellar joint. So all our tibias in the last 15 years are done suprapatellar, especially in complex procedures. Here you see the X-ray grid method and the start of the bone transport, and this is the minimal invasive drill bit osteotomy. This fragment is pushed onto this fragment, and this fragment is pushed onto this fragment, and finally this is the cause of distraction, and finally we could achieve a very nice consolidation of both dockings without bone grafting after 12 months. So this was a tour de force across the issues, some issues of what we call 3D surgery. And if I could raise your interest, I want to invite you to our 6th international course in Munich in September 2025. You will have the chance to join cadaver labs, bone labs, planning labs, and many practical tips by an international faculty. And the last day of the course will be the cadaver lab. And after the cadaver lab, we will start the Munich Oktoberfest 2025. Thanks for your attention.
Thank you, sir. First of all, we all will like to thank you on behalf of Asami India to spare your precious time and be with us and presenting an excellent talk on it. Yeah, so I hand over to Dr. Bari.
Okay. Professor Taylor, hello.
Yes.
You remember me, Dr. Bari
Nice to see you
speaking from
again.
Bangladesh.
Yes, I remember.
You remember? So you had a very good talk. And
Thank you.
I would like to ask you a question from the audience. Anybody want to ask any question? He's a well-known reconstructive surgeon from Germany, Professor Taylor. And last time we had been in Malaysia, few months back.
Yes.
Any question?
Yes,
Yes, sir.
Peter, the question from me, Milind Chaudhary. Can you
Hi,
please-
Milind, how are you?
Good to see you. Can you please
Good to see
describe
you.
your latest version of the rigid, straight intramedullary reamers that you use
Yeah.
and special care you take in reaming, please?
Yes. We very early we learned that, especially when we use lengthening nails or bone transport nails, those nails have to be straight. They cannot be bent because they would bend even more. So all those nails are straight, and we learned that if you use flexible reamers, the flexible reamers follow the path of the femur, which is curved inside more than outside, and also the tibia is curved to posterior. And we learned that we need to use rigid reamers, front-cutting reamers, not to over-ream too much and to maintain stability. So with rigid reamers, we only need to over-ream 0.5 millimeter of the size of the nail, which causes high stability and the best treatment results. So, Milind, your question, there is no new generation. It's the same as 20 years before.
Okay, thank you.
Next. So, question?
Thank you, sir. Thanks a lot for joining us. And we will continue with our second talk by Professor Hemant Sharma. So I will like to request the audiovisual team to please connect Professor Hemant Sharma's talk.
I will stay online until the discussion, okay?
Yes, sir.
Hi guys, can you see my slides?
Yes, sir. Yes.
And can you hear me?
Yes, sir.
Brilliant. So I bring greetings from Hull. It's in England, in the middle of England on the east coast. It's an old town from about 11th century. We've got a number of things, and I'm sure some of you have visited us in Hull. I also, hang on just 1 second, it's not working. Greetings from Yorkshire, and Yorkshire is a beautiful part of the country, and you're all very welcome for your holidays, and especially in summertime, it looks absolutely gorgeous. I work in a hospital. We've got two big hospitals. It's quite a large hospital. We've got our own university, we've got our own medical school, and hospital was established in 1782, and we pretty much provide whole extension of services across the board. But the most famous son from Hull would be William Wilberforce, who fought against slavery, and because of him, slavery was abolished and in the British Empire a while ago. My name is Hemant Sharma, and thank you for inviting me. Thank you, Rajat, Shamshul, and the Assami committee, Assam India committee, for giving me this opportunity. And it's an honor to be coming back to home and talking and sharing my experience with my colleagues and friends and my fellow speakers. And I know a lot of people in audience, and I'm sorry I couldn't be there, which is a big disappointment. I'm going to talk about mechanical biology and the management of non-unions. Now, what I hope to achieve is that we look into a standard practice and our understanding of the problem, and we can discuss some alternate solutions, and hopefully, I can persuade you to change your thinking about the non-unions a little bit, and your approach might be a little bit different, or at least change or start questioning some of the standard approaches. Now, if you look at the bone healing, it basically needs two things: biology and the stability. And these are the two simple things, and you can put it in either way, and it works out in a same system, whichever way you look at it. Can I suggest you consider biology and the stability or the mechanics, consider them together rather than separately as a problem. And there are other things as well, which we will not be discussing about the patient, about the problem of the bone, deformities, and of course infection, which will not be talking today. I'm just going to show a case, but the idea would be that there's a completely separate work and discussion we need to be done separately. Now, we all think, and the consensus view is that there are two types of non-unions. One is a step, or we call hypertrophic, which is we feel the biology is same and the stability is an issue. And there's an atrophic, or the mobile non-union, which the consensus is that it lacks biology, so needs bone grafting and provides stability. And apart from bone grafting, we also need to provide the stability. Now, if you look at the histology and the atrophic non-union as a whole, there is nothing to suggest it is actually avascular. The blood vessels are present, the cells are present, and the cells not only are present, but they behave in a pretty much similar way like normal cells. They're not doing a lot, they're just sitting there static. So if you look at it and consider, actually, does atrophic non-union is avascular? Does it actually exist? I think not. All atrophic non-unions have enough biology for it to heal the bone in almost all scenarios. So why don't we consider bone healing in terms of a mechanical problem like strain? And our current problem at the minute is that most of our work or our clinical practice is based on biology. We put too much importance on biology in bone grafting, preparing the bone, excising the bone, but we do provide stability, but I think our main focus seems to be on biology than stability. And the biology behaves in a certain way depending on the mechanical environment, and the concept is not new. It's been around for a while, but we haven't sort of dug deep into it and paid a lot of attention to it. So I'll give you this case. There's a young lady, smoker, had iron nailing for a fracture 18 months ago. Her problem is the pain. She can't walk, difficult to work. She's a manual worker and she's struggling. So if you look at it, this is clearly a non-union. Alignment looks satisfactory. And the nail, there's no suggestion of infection, and there appears to be a non-union. Her problem is principally, if you look at it, that your problem is that oblique non-union, and apart from that, the long working leg, the instability is also causing the pain. And our current problem is that this area has got suboptimal strain. That the mechanics in this area are not ideal for this fracture to heal. If you look at the strain, again, the concept is not new. Stephen Perrin published a work in Clinical Orthopedics 79, and he published some more work in 2002 in Journal of Bone and Joint Surgery. And again, David Elliott published their work in Bone and Joint Journal in 2016. And the concept of the strain is that the cancellous bone and the cortical bone needs an optimal amount of strain, which slightly vary, up to about 2%, sorry, up to about 10%, that it is ideal for bone healing. And anything below here and below C will not form the bone, and between B and C you will form the bone because the strain is optimum. Either side you get a non-union, you get granulation tissue, all kind of things happen. So how does the strain behave in a normal fracture? So if you look at a fracture, so this is a comminuted fracture. So this is a piece here, and there's another line coming out here which is not very well seen in this X-ray. And if it's a comminuted fracture, it's a low strain environment, and therefore the intramedullary nail seems to be a perfect solution for that. If you look at the transverse fracture, it is a high strain environment, and IM nail will do the job, but it's not the ideal implant for it. And therefore you will see in all our clinical practices that transverse fracture seems to have a delayed or takes longer to unite in patients who have gone IM nailing. So in time, how strain changes. So what happens is that, so you have all these fractures here, and all this bit has healed, and all is left is one bit which hasn't healed. So, and I have to admit, the vast majority of the patient will heal. So at this point, when all of the fractures have healed, that the one piece hasn't healed, then what happens? So either the bone can heal, or the non-union develops. Now, what happens is that because of the comminution of the fracture, it was a low strain environment. When this is healed, you are left with a single line of non-union, and therefore your strain changes from low strain to high strain environment. And it can be a transverse non-union, or it can be an oblique non-union where the shear is a problem as well. So if it is a transverse non-union, all you need to do is add in a plate. You don't have to do anything else. It just optimizes the environment, you make it more stiff, and it heals. And if it's an oblique fracture, like if we come back to a young lady who we discussed before, so all you need to do is go in and put a couple of screws to make it stable. And then the screws were loose, so I put those screws back as well to improve the mechanical environment. And when she came for a wound check 2 weeks post-op, all the pain was gone. It can be done as a day case surgery. And by 8 weeks, she was walking around doing everything, not far from healing. And the next visit she was completely healed. And this is a lateral view. And if you can see, there's a 2 screws, which is just gone across 90 degrees to the non-union side, optimizing the strain. And again, 8 weeks and 7 months. And she's pain-free, completely healed, and gone back to work. Now what happens is that the strain environment changes, and then how do we deal with it? So this is an example where you see a periprosthetic fracture, and what happened? So this was fixed. Now it is not obvious on the previous X-ray. Again, the fracture was coming down here, so they put it few other bits and fill the femur. And in 9 months, the plate breaks. Now, why did this happen? Because what happens is that the comminuted bit here has healed, and it ends up with a transverse non-union, and which basically means the strain has changed, and plate is taking too much load. So all it needs is you align the bone, you need double plating or any other way you want to optimize the strain. It doesn't need bone grafting. And in 3 months, it is pretty much healed. Now, can it be prevented? Yes, it can be prevented. If you see the one bit is not healing, and then you can go in and provide extra rigidity. Now, it's not very easy and obvious to do that because these things don't behave according to the X-ray pattern, and sometimes we see in clinic, but and despite the best efforts, these things do happen. But if we can recognize it, it can be prevented. So what about bone grafting? Now, we do bone grafting because we think it provides the growth factors and enhances the bone union. But if biology is not a problem, then there is no reason for us to bone graft any non-union. So my take-home message for non-unions is that bone graft is rarely required. Almost all non-unions can be healed by addressing and changing the mechanical environment, and pretty much all of them can heal without any bone grafting. And a part of it is that we have trained and we come in a way where we believe that the certain thing is true and we just keep following that. And I think we need to start questioning ourselves that why we are doing that. Then what about the black holes we see on these on our X-rays when you have a case of non-union? But then if you see what is in this black hole is fibrous tissue. When you do an laser frame, we lengthen the bone. That's a fibrous tissue as well. So this fibrous tissue and this fibrous tissue is pretty much same. The only difference is this is mechanically static because nothing is happening, and this is a dynamic environment because you're doing something to the fibrous tissue. So all you need to do is change the mechanical environment in this area to optimize it without bone grafting for it to heal. That's all you need to do. But there are times where you have to bone graft. When there is a large gap, you have no option but to bone graft, and that is probably the only indication for that. And if you look at it, non-unions doesn't need to be opened. All non-unions can be treated closed. And when do you open a non-union? It's probably when there's infection, active draining sinus. You probably have to excise sequestrum and do usual debridement, but very, very minimal bone resection. If it's a gap non-union, or there's a metal where it's broken, which is preventing the close treatment, and is a classical pseudarthrosis. These are probably some indications where you have to open the non-union site. What about the infected non-union? As long as it's quiescent, it's hypertrophic, you don't really need to open it. And this is an example. This is a young man, had a pilon fracture, it was closed, had ORIF fixed, went into deep infection, had incision drainage, and ended up with deformity and stiff non-union. This is 3 months post-IND. Infection settled, and all you need to do is put in a frame, distract it, close treatment, and it heals without any problems. So in these cases, stability is absolutely critical. And in subclinical infections, or the infection when it's quiescent, it's settled, they can be treated closed. They can be treated as a sterile non-unions without opening and debriding these. So if it's a hypertrophic non-union, what do we do? If there's no metal, we can put an X-fix and distract. If it is iron nail, and depending on if we want to optimize the strain, we can add a plate that will optimize the strain, help it heal the bone. If there's already a plate, you can put a second plate, or you can remove the plate, put an X-fix, and distract. If it is an atrophic non-union, then only thing you need to do is compression. And if there is a gap, only then you need to bone graft it. But strain optimization is critical, and it almost always works. Our problem is we don't know how to calculate the strain and measure strain, but a clinical practice, if you look at the clinical scenarios and X-rays, provide enough information for us to manage these non-unions reasonably well. Is this gospel? It works every time? No, it doesn't. There are failures. There are times we can optimize the strain, and there's times I think we don't understand the problem fully. First, for most non-unions, this approach works. Some will need more surgery and occasional bone grafting. We don't know which ones are those, but the vast majority will heal by just optimizing the strain and changing the mechanical environment. So how did my practice, what is the evolution, how did my practice evolved? I used to do bone grafting regularly. Now I rarely do bone grafts for any non-unions. Previously I used to do for infection, segmental excision and lengthening. All I do now is soft tissue debridement, minimal trimming, local antibiotic stable with no bony excision. But this is for infected non-unions. And this is active infection, active infections. If it is a quiescent, then I treat them without opening them. And I think one of the things I've learned in time is that more I read, more I talk to my colleagues, and some of them are here in the audience and my fellow speakers, the more I speak to, the more I learn, the more I realize how ignorant I am, and there's so much more I have to learn. And can I invite you to the Hull Deformity course, which we are holding in June this year. You're all invited. The subspecialty day this year is malalignment and knee complex. We also have a book which you can only have free. You can't buy this book because we are not selling it. But if you want to download it and have it free, you can go to the course website and download it free. Thank you very much.
Thank you, sir. Thanks a lot. Thank you, sir, for the wonderful talk. We all were at the traditional teaching of bone grafting every time, and we really got our concepts changed. I request Professor Bari.
Hemant, Bari is speaking.
Hi, Bari, how are you?
Fine. What about you? Oh, good lecture. And you enjoyed your lecture. You deliberately, everything you told, nothing, without bone grafting. And what's your last message for the young stars, those sitting here, regarding the bone grafting? And you told everything. Elaborate. A message to the young stars, those who are sitting, how could they will proceed with infected non-union and atrophic non-union, with bone grafting or without bone grafting. Okay?
Thank you.
You understood my question?
Okay, so sorry, I thought you were saying, do you want me to give a message? Okay, sorry about that.
Yes, message.
I misunderstood, my apologies. So I think for younger surgeons, I think what they need to look at it is, rather than looking at non-union as a non-union, we need to look at every non-union and identify what is the cause of the non-union. If we identify the cause and we eliminate the cause, that should heal the bone. Bone grafting is not a solution every time. You can, for example, is a nail, you can re-nail. But you can easily put 2 screws or a small plate as a day case, and that will do the exactly same thing, much cheaper for patient, much less morbidity, and much easier. Atrophic can be a little bit challenging, and also they need decent compression, but also I think we need to remember that not everything needs external fixation. The internal fixation can work equally well for patients. We need to look at it, what works best for the patient and for that non-union, rather than what we think is the best and what we are good at. We need to look at the patient personality, we can look at the non-union personality, and then decide our treatment. Infected non-union, I think we need to leave out from this topic because it's a totally whole different ball game. But only thing I can say is the days of segmental resection and the large excision up to the paprika sign are gone. We need to do the minimal resection, the local antibiotics, and stability, which will work equally well in almost all cases.
Okay, Hemant, Ram here.
Hi.
So actually, those cases of the aseptic non-union, which shows the atrophic, it means there is no vascularity, there is no regeneration of the bone. So how we can treat them without bone grafting?
So this is what, there is no evidence histologically that actually there is that the vascularity is a problem. I think the problem is that the vessels and the growth factors are not doing anything. Those cells are not active, and we need to make them active. And this can be done in most of the cases by compression and providing stability, and that works in most of the cases. And again, as I said, that it is we cannot always optimize the strain because understanding is not very good, but in most cases it works. If you compress, stabilize, that should heal even the atrophic non-unions because the vascularity is not a problem there. Biology is not an issue.
So Hemant, this is Dr. John Mukhopadhyay. And
Hi, John.
I totally agree with a lot of things you're saying. The problem for us in practice is that when we do the surgery, we want that to be for the last surgery for sure. So we do bone graft in situations where maybe you do not need to bone graft, but because we don't want to go back in there, we would use bone graft in some of these situations, especially the atrophic non-unions. The hypertrophic non-unions basically need stability, and there's no doubt about it. And I agree that a lot of atrophic non-unions which we bone graft, we actually don't need to bone graft. But we sometimes do it just to be sure that we don't have to go in again to do the bone graft.
No, John, I totally agree because I think it is also depends on the
Kind of practice you have and
the
where you're
health
working.
system, the economics, and
Absolutely.
the patient personality. And for example, you guys get patient from all over the country from far off places.
Yeah.
And if you, in some doubtful cases, you want to do bone graft, and that I don't think that's as an issue. But I think what that we don't need to every time do it, but sometimes I totally agree that we do it just to.
And I agree
just to
that
be
you need to
different.
really look at the cause of the non-union before we treat the non-union.
Good afternoon, sir. Sir, I'm Dr. Saurabh Jain. I will be joining you in probably in June, sir. I have a question, sir. Since these are all diaphyseal, you have shown X-rays, the diaphyseal non-unions. So the X-ray you showed for the femur, since there was an axial loading will cause a union for this. If you apply a plate over this, then the axial loading will cause a fracture over the plate because you need an axial loading in these diaphyseal fractures. The question is separate regarding the bone graft, but rather than using the plate for these stability. Do you understand?
So your question is that
Adding a plate in diaphyseal fractures for stability, sir. So it will, when the patient axial loads it, it will cause a more stress on the plate and the plate will be bending. So example you showed for femur, all the distal screws were broken and you have probably exchanged the nail because that axial loading has caused automatic dynamization has been occurred, sir. So for diaphyseal fractures, adding a plate over the nail will hamper the biology of axial loading in these fractures, sir. Absolute and rigid stability, both the concepts are being taken together, sir, actually.
So my belief is totally different, and I think the axial loading is fine. But I think what you're trying to do is, I think first of all, the concept of dynamization of a nail is totally misplaced. Dynamization actually causes a lot of instability, and in some cases it works, and I do not disagree, but those cases are fairly limited and small. In most cases, dynamization is actually misplaced concept because what happens is that it produces instability and sometimes the rotational instability. The issue is that the mechanical stability is provided by more than one thing. If there's an oblique fracture, you can put 2 lag screws, and the plate what it does is in that case that it prevents the shear. That was the plan in that case, or you can put 2 lag screws. The idea is that it is ultimately you come down to the optimization of the strain in whichever way you can do it. That you need to make that constructs more rigid because it's not healing. And we do not re-nail in a femoral non-union or a tibial non-union. We just put a plate on top of the non-union or lag screws. We do not re-nail, and the results have been fantastic. Generally, we have occasional failure, but almost all of them heal because we have optimized the strain. So my belief is, Saurabh, is totally opposite of yours.
Hi, Hemant. Very good talk. Thank you for opening our
Thanks,
eyes
Alan.
to this concept. How close does it come to this concept of reverse dynamization? Is that, to sum it up in 2 words, is that it? Or it's a little, goes beyond that?
I think this goes beyond that, because I think reverse dynamization, all the Vedas work has come round and is principally on the earlier part in the fracture healing. And I think a strain is an extremely important part of reverse dynamization. But I think once and if you look at the Ken Wright's work from Oxford, when they published their work in earlier part and said that about the micro motion, and one of the very important things they wrote in the paper was, which is often ignored, is that they said as the fracture heals, it needs further stabilization until it fully heals. And the Vedas work on all the animal studies have suggested in the reverse dynamization exactly the same. And we are just doing the same. We are tackling the latter part of the reverse dynamization.
Okay.
And the Ken Wright's work. So they're kind of related, but not exactly.
So it wouldn't be wrong to summarize by saying you need reverse dynamization in the beginning and dynamization only at the very end.
No,
If at
I
all.
believe there's no dynamization at the
At
end,
all.
more
Okay.
stiffness at the end.
All right. Thank you. Thank you.
Yeah. Hi, Hemant. Dr. Shah here.
Is there time for another comment?
What I wanted to think of, this was excellent, a very good concept. Supposing I have put a ring and it is failing, and using your concept, I add a few olive wires from the other side to stabilize it more without doing bone grafting. You think on the same concept, based on what you have said, it may work?
That depends. So if you are putting olives to eliminate the shear, then it should work, because all you're providing is, and you're providing either screws or olive wires to eliminate the shear, and then your frame becomes a neutralization device. So as long as that is eliminated, then yes, it should work. And I think Elizarov has shown it, and a lot of nailers and platers have shown it that, and actually I've got a lot of cases where I put 2 screws within the frame to eliminate the shear.
I might have done like
work.
that without even realizing that what you have said or thinking in those axes. It's a very good concept you have. Thank you so much. Excellent.
Can I give a comment? Thank you. I fully agree, Dr. Sharma, about your optimizing the strain, about many colleagues do too much bone grafting, but I don't agree in dynamization. If the nail is stable and if you have total axial stability, dynamization is a great thing. Only if the nail is too thin or if your blocking screws are not tight enough to the nail, then you have another problem of micromotion. But especially in the shaft area, if the nail is really tight, dynamization is a good thing.
Yeah, I mean, so I totally agree with you that if the nail is stable, then absolutely fine, and I do not disagree. But my problem is that the dynamization is used as a concept with a thin nail, an unstable nail, and they dynamize it, and that's a problem.
This is even worse. This is even worse then.
And that is the reason I say that it is an important concept, but we need to know why we are doing it, and stability is the primary thing. Yes, I totally agree.
Thank you, sir. Thank you for the wonderful discussion. Now I invite Dr. Robert Rosebrook from USA for his talk. Thank you, sir, for joining us. Please share the screen.
Thank you. Thank you. It's my pleasure. It's my pleasure to be here. I appreciate the invitation, and let me share my screen with you. Okay. So, again, thank you for the opportunity to present to you on a new concept, a relatively new concept, called osseointegration limb replacement surgery for amputees. And what I'm going to show you is my experience using it as a single-stage surgery as an alternative to amputation using a socket. So many patients with many amputees who wear sockets have a variety of problems related to their sockets, such as skin ulcers, perspiration, the need for frequent refitting, poor fit, changes in sizes of the residual leg, and they feel instability. And a lot of this is related to poor fit of the socket. It's also related to a lack of stability and even malalignment, as is illustrated in this photograph, where you see the bone is going in one direction and the prosthetic is going in the other direction. So the malalignment, the instability, these are that dissipate energy and lead to functional problems. With an osseointegration limb replacement, there is a direct skeletal connection, and you can see how the mechanics and the stability are going to be improved, illustrated by this patient before and after. Now I'm going to speak to you mostly about single-stage osseointegration, which means that you can do the entire surgery in one single stage. Let's look at an example. This is a patient who is in his mid-30s. He's a physician in the United States, and he has been an amputee wearing a socket for a few years. He's having some problems and wants to improve his quality of life. At 3 weeks after a single-stage surgery, the implant is in, and this is what the aperture looks like. So the implant is inserted, and the connection points to the outside world are all established in one single stage of surgery. And then at that point, whether it's 3 weeks or 4 weeks, depending on each individual patient and the quality of the bone, we start a loading program where we gradually increase the amount of weight that the patient puts on the implant gradually over a few weeks. And in this particular case, at 6 weeks, we fitted him with his prosthetic leg. So this is a 6-week x-ray and 6-week clinical visit. We start him walking on crutches. And then gradually, the crutches are removed. So this is him walking at 4 months. His gait is already, a lot better than it was beforehand, and he has increased stability in his prosthetic leg. So let me tell you about the surgical technique. First thing, these are custom fitted or custom made implants. So we get a CT scan, so we have a very good sense of exactly the size of the implant, how much bone is necessary to be resected in each individual case. In surgery, the implant is impacted in position. It's a porous coated titanium implant. And so it has a lot of the same feel as impacting, for example, a total hip replacement. And when I first started doing this, I started thinking of it as a reverse hip replacement. The soft tissue handling is an important part of this treatment as well, and that is something that has to pay a lot of attention to. We contour and eliminate excess soft tissue. We stabilize the underlying muscle platform. We stabilize the overlying skin to or near the bone. And in some cases, as I will show you, if you can, a percutaneous approach can be used, and it can be simplified using that if it is possible. If there is substantial nerve pain, we will do a nerve reconstruction using either the TMR or RPNI techniques. This is an example of a intraoperative case. The implant is in place. A sciatic nerve neuroma is identified, and it is dissected free. And then what a TMR is done here, where the sciatic nerve, the new cut end of the sciatic nerve, is attached to an adjacent motor nerve, to an adjacent muscle. And that's an example of what's called TMR, or targeted muscle reinnervation, that has been shown to vastly improve the problems of phantom nerve pain. The other thing we do is we do a purse string for the muscle. And so I'm trying to illustrate with a picture of myself wearing a hood that there is a space. And what we want to do is tighten that space. So we want to tighten the muscle platform around the implant. And that is what is done here in surgery. At the end, we'll take the muscle, the anterior muscles and the posterior muscles, and pull them all together. And I will try to illustrate that to you. And then the posterior flap is often pulled around the front. So the point where the point posteriorly, which is red, is attached to the blue point in the front with the stoma. And so it looks something like that, right? The muscle platform has been made, and then the stoma is created around that. And so this is what it looks like in surgery, and this is how we will leave the operating room. We have been successful in cases that are quite challenging. This is a patient who has a very, very short femur, and really it is completely impossible for her to wear a socket in any kind of meaningful way, and she walks around without a socket. We custom made a implant for her based on CT scan measurements. This is the insertion of the implant in surgery. In this case, I left the lateral plate because I did not want to weaken the bone. That's what the implant looks like. Again, a porous-coated titanium implant. These are what are called dual cones. Those are the abutment pieces that have various lengths to clear the soft tissue. We start out with a rubber footy so that you can start with weight bearing, and then the leg is attached at a particular amount of time. Usually the leg is attached anywhere from 6 to 12 weeks after the single stage surgery. She became very, very active, starting to do activities that she was not able to do at all prior to this. And just to illustrate, this is the preoperative gait, without even wearing a prosthetic. It was not possible. And 1.5 years after surgery, she has been able to regain a very meaningful lifestyle, walking on the beach. She's now about 4 years out, really doing phenomenally well. Let's switch over to the tibia. We have used this technology for transtibial amputees, and in the tibia, patients who have a short residual tibia can sometimes have difficulty, or again, if they just want to improve their quality of life and their stability. So in this patient, again, we inserted a tibial implant, porous-coated titanium. There's a period of loading, then the prosthetic leg gets attached. That is what the aperture looks like. The patient is illustrating the ease of removing and applying the prosthetic. And again, illustrating the kinds of functional activities that he is able to do because of this stability. These are activities that patients with sockets have a difficult time doing because of lack of stability. We're finding that patients are doing more, they're wearing the prosthetic for many, many more hours in the day. Their get up and go times are significantly improved. We've been engaged in a variety of observatory studies, observation studies, and we've been fascinated by the short implants. Sometimes you're left with a difficult case and the patient has a short residual limb, and we've actually found that the short implants do just as well as the longer implants. We've pushed the limit, illustrated in this example. Khalid had been recommended for a conversion to an above-knee amputation by many surgeons because he just had a lot of instability. He couldn't wear his prosthetic for too long in the day. And so even with a short residual limb and a short implant placed, I will show you that we're able to save his knee. He has control of his leg, and this is a much better solution, obviously, than converting to an above knee. But a socket was not giving him the stability that he needed. Another interesting thing that we have observed is that positive intraoperative cultures do not lead to significant problems. So what do I mean by that? In all of these patients, given that they have histories, I do surveillance cultures, right? These are not actively infected cases, but I will do surveillance cultures, so I will swab the canal. And I have found that about 15% of those patients will have positive surveillance cultures, which doesn't mean it's an infection, but it does mean that there is some bacterial contamination in the canal. When that happens, I will treat the patient. After I've put in the implant, I will treat them with 6 weeks of antibiotics. And we have been pleased to see and report that these unexpected postoperative intraoperative cultures do not lead to increased postoperative events. This is an example of a patient like that. He had big trauma. He has irregular soft tissue, a lot of difficulty wearing a socket. Again, he came in using just crutches. This is in New York City, where patients have, tremendous, opportunity to get sockets, but it doesn't matter. It's like, it doesn't matter how good the prosthetist is. If you have a soft tissue situation like this, it's very difficult for a patient to get a comfortable fit. So we went in through a limited incision and trimmed the ends of the bone, and again took intraoperative cultures. His cultures were in fact positive. We treated him with antibiotics, and it did not affect his postoperative result. So we found that in this subgroup of patients, it actually did not lead to postoperative infections. This is an example of a patient who had an amputation as a child, and you see the typical type of overgrowth with a pointy femur. One of the concepts here that is important for osseointegration is you have to trim the bone back. You're not trying to maintain the absolute maximum length. You're actually trying to trim the bone back to the appropriate level. And here we had to do that to be able to get in a reasonable sized implant. So you'll see we'll make the residual bone a bit shorter to get an implant in that is of sufficient size. And again, it's a porous coated titanium implant, single stage. These are some pictures from surgery. This is illustrating the purse string, the muscle around the base of the implant, creating a stable muscle platform, right, where you create a barrier and you eliminate excessive motion. And then then there's a flap, and the idea is to take the flap, pull it over the end, and create an aperture. So based on the soft tissue tension, you decide where to make the aperture, and then you connect the posterior point to the anterior point and pull it over. This man is engaged in mountain biking. He drives a very big truck. Patients report that they have increased sensation and what we call osseoperception or proprioception through the bone. They can feel the vibrations much better. They feel pressure much better, and it allows them to have a sense of increased sensation and feel within their bone. This is a patient who was also looking for a higher level of functionality, and he was an athlete. In this particular case, the soft tissue situation made it possible to plan a percutaneous approach. And so a couple of interesting points for the tibia is, we use the CT scan to figure out the optimal implant. In this case, it was a 20 by 130 millimeter. In the tibia, the diaphyseal part is only the distal part, because you end up you're going into this open funnel-shaped part. So the stability relies on the diaphyseal fit, but you also want to impact the bone in the metaphyseal region. So when you're doing this, you only want to ream part of it and you want to impact the rest of it. So here the stoma was made in a percutaneous fashion. Here you can see we only reamed really the distal 2 to 3 centimeters, as much as you feel is diaphyseal. And the rest of all the metaphyseal bone is actually impacted with the rasping technique, so that the metaphyseal bone actually becomes quite hard and quite stable. And so this is what it looks like. And if you have the ability to do a percutaneous operation, as we did here, it's much quicker. And you see this is what it looks like. The indications here are if there is no need for a lot of soft tissue contouring and if there is no significant nerve pain. And really it's not going to be a problem to use a percutaneous approach. And in many ways it's like putting in an external fixation pin. Amazingly, at 9 months after the surgery, this man ran a marathon, 26 miles. And this was not something that he was able to do with a socket. So these are the kind of improvements in functionality that we are seeing. We looked at some of our data on percutaneous versus open, and we found that the percutaneous confers a big advantage for lower need for IV or postoperative antibiotics during the first and after the first 6 months, comparing those two groups. And not surprisingly, the percutaneous group had shorter operative time, lower blood loss, lower infusion volume, and shorter length of stay in hospital. So if you have the opportunity for the right patient to do it percutaneously versus open, there is a big advantage. Now, of course, there are complications that can happen with this technique, and they basically fall into two categories. One is through the soft tissue or the aperture, and the other is bone. We do see some cases of hypertrophic granulation tissue, superficial infection, sagging and impingement. All in all, they're not difficult complications to deal with and don't really lead to significant problems. With the bone, we have seen a 7% fracture rate in our experience, which is similar to other centers. These are fixed with periprosthetic techniques. Osteomyelitis of about 5% and loosening of about 2% that required the removal of the implant. When there is a fracture, we use the periprosthetic fracture techniques, and that has been successful. And there are even some cases which you can treat non-operatively. The last case I want to show you is a bit of an unusual case, but also illustrates, I think, the power of this technique. This is a patient who had a traumatic hip dislocation and had chronic regional pain syndrome and a chronic hip contracture for 10 years. Basically, her level of function was horrible. She was using 2 crutches and a brace and was in chronic pain. You can see from the x-rays what she looks like and what her hip had sort of turned into. And there wasn't a great solution for her. And she came to see me, and we took a pretty radical and aggressive approach of doing a hip disarticulation and osseointegration. I wanted to increase the bone stock for the osseointegration, so I left the proximal femur and did a combination of a hip fusion. And again, the hip fusion component here is to increase the bone stock for the implant for the hip disarticulation. So this is what it looks like. And so we started loading her. At 5 months post-op, she's walking with 1 crutch. Again, remember, for 10 years, she needed a brace and 2 crutches with pain. You see already the progress that she is making. Her progress continues. This is the first time in 10 years that she's walking without a crutch, 2 crutches. You can see here the double hinge at the hip and the knee. This is 10 months post-op. from a single stage surgery. So in summary, I will tell you my experience with osseointegration has been really fantastic. Patient satisfaction is very high. We eliminate the socket, we get rid of that tight feeling and nerve pain, sweating and blisters. Patients report that their control of their leg increases, the endurance increases, the time that they wear their leg increases, their get up and go scores improve dramatically, and they have an increased sense of proprioception because they feel the vibrations and pressure in the bone, also known as osseoperception. I thank you for your attention.
Thank you, sir. I must say that I think most of us have seen something like this for the first time. It's a real integration of bone and machine. So thanks a lot for this wonderful talk, and like it opened our vision like what are the things possible in future. And I pass over to Dr. Millen for his question.
Wow, Rob, thank you for this fabulous talk and some exciting results. Just two quick questions. You did
Yes.
publish an article in the JLLR about lengthening the really short stumps using either the precise or the external fixation to get in a better fit. And so now have you abandoned the need for lengthening very short stumps? What's the latest?
Yes, Malin, that's a great question. And I have to say that, yes, in fact, I have changed my opinion about the threshold for that. I have experience with one case where I did a lengthening of a short residual femur in preparation for an osseointegration. And I will tell you that, and then I have experience of not needing to do that because we use a short implant. And I think that my threshold for doing a lengthening surgery to fit an implant has really gone up. And in most cases, I will actually use a shorter implant. And as I've shown you, I mean, I've used in the tibia 5-centimeter implants. I just did one that was 4.5 centimeters. And in the femur, I've done as small as 8 centimeters, but I've done a few that are 8, 9, 10 centimeters. So in cases like that, I'd rather put in general, a shorter implant and avoid the lengthening surgery. As you can imagine, lengthening a short residual limb like that is not an easy task. It's a complicated task.
Yeah.
And so I think this is a quicker, more reliable way to get the patient to a higher level of function.
Great. And I just wonder, is there any role for, say, iodine impregnating the implants at the interface to keep the stoma potentially free from infection? Do you think, what are the worries that you have now going forward? And
Yeah, I think, I think you're asking great questions. And so, everybody is concerned about the opening of the stoma. And I am too. But I will tell you that it's less of a problem than you may think it is. And I think, being comfortable for those of us who have been putting on external fixators for many, many years, in a lot of ways, I think about this like an external fixation pin.
Okay.
And it behaves a lot like that. So we all know that if you put in an X-fix pin, and if you put it in percutaneously in the tibia, and you have good stability, and if it's like a hydroxyapatite pin and the bone grows into it, then those pins do very, very well. If you put the pin through a lot of deep soft tissue, it becomes a bigger problem. So, I think some of the principles are, try to make the soft tissue move, the mobility of the soft tissue as little as possible to help prevent soft tissue infections.
Okay.
We do try to put some local antibiotics at the bone implant interface, and the latest thing that I've been doing routinely is I will take some vancomycin powder, mix it with some saline, and create a paste, and I will coat the end of the implant so that as I am impacting it, I get some local antibiotics in that area. And I think that that may help. It sticks around for maybe a week, a few days, whatever. But the key thing is creating a good fit, getting ingrowth of the implant so that you create a seal at the bone implant junction, so that if somebody does develop a superficial infection, it really stays in the skin and doesn't actually invade into the bone and create instability or loosening of the implant. The stable muscle platform creates a situation where there's less mobility of the soft tissues, creates a seal, and you get this really nice seal. A good way to think about it is a seal between scar tissue and bone growth that prevents a superficial infection from going up. And the other thing that protects it is it's an open system, so you get a little bit of drainage as you may need it, just like with an X-Fix pen. So they don't turn into, it's very uncommon for them to turn into significantly big infections that turn into big problems that require loosening of that loosen implants.
Great. Thank you. That was really elaborate and wonderful results. Do you also
Thank you. Thank you,
perform-
Milind and colleagues for inviting me to participate in this wonderful international symposium.
Thank you, sir. Thanks a lot. Thank you, sir. Big round of applause. And now we will be starting our talk by Professor Gamal Hosni. Welcome, sir.
Welcome. Thank you so much for inviting me, sir. It's an honor for me. Is it okay now?
Yeah.
Yeah? Full screen?
Full screen.
Yeah, okay. It's a privilege for me to present my talk in Assami, India, and I would like to thank the organizing committee and Agrawal for inviting me. I'm going to talk about tibial hemilia, a new perspective, new classification, new ideas. The problem with the congenital deformity is that you might think that you are propagating science, but actually it's branding, not science. So if you talk about the amputation option, the people talk about historical option, but when they talk about reconstruction, they use the words new, recent, advances, perspective. Actually, it's promoting the ideas. It's not science, it's branding. And they always talk about the indications of amputations, but in our country, there is no indication for amputation. Whatever they say, that the people, they don't accept amputation. I know in India, perhaps it's the same. So we don't talk about amputation. So just one choice, the reconstruction. The problem, which I think is very important, the volume of surgery. Many people, they give classifications and sub-classifications, 1, 2, 3, 1, 2, 3, 4, 5, and they have very few number of patients. And each one has to name a classification after his name. But learning surgery is very important. Meeting patients, operations, pathologists. What do you mean by the surgical look? If you want to talk about total knee arthroplasty or any other surgery, they always talk to you, how many operations you do per year? So if you talk about total knee arthroplasty, if you do less than 70, that means you are a casual surgeon. It's very difficult to take an opinion from a casual surgeon. But when you talk about congenital deformities, you will find a paper talking about 10 patients, done over 20 years, in 6 centers. So each surgeon has the experience of 0.1 patients every 10 years. And I remember I was in a symposium, and one of the surgeons talked about that himself. He said that I'm the greatest experience in tibial hemimelia or something like that. I told him, okay, the number of patients you presented in your life is less than the number of patients in the outpatient clinic in one of our pediatric hospitals. The problem with the classification that it's very difficult to do a classification where most of the people were treated by amputation in the first year. You know, the classic treatment or the conventional treatment was to do an amputation before 1 year, so the patient and the family will consider it as congenital amputation. The second thing is that most of the classifications were based upon patients diagnosed at birth without follow-up. The third problem is the animation-based classification. What's animation-based classification? This is the new expression nowadays. That means you make your classification, you think about it, and you decide it, and then you apply it to the patients. You know how to make a classification? You know, you collect hundreds of patients, and then you see the X-rays and the follow-up and 20 years, then you decide to do a classification. But it was the opposite way around. So the animation-based classifications is a new trend. And this is the classification we developed over the last 40 years. We have 283 cases with the follow-up and their treatment options. This classification, 6 types. Type A, you have a complete tibia, which is short tibia. The fibula is normal. This is type 1. Type 2, absent distal tibia. That means you have more than 50% of the tibia. Type 3, absent most of the tibia. That means you have less than 50% of the tibia. Type 4, you have diastasis between both of them and the talus in between. Type 5, the fibula is normal, short tibia with diastasis of the whole tibia. Type 6, 60% of my patients are type 6. Complete absence of the tibia. So we want to think about the treatment. We always think about type 6, complete absence. Then followed by type 2. Type 2, we have 11% of the patients type 2. And type 3, we have 8% of the patient type 3. I'm going to describe the treatment of all these cases. But remember that type 6, type 2, and followed type 6, 60% of patients, then type 2, then type 3. Also bilateral cases. The problem that we have bilateral cases, maybe in 30 to 40% of cases in the literature. The second problem we meet with the classification is the follow-up. That means most of the paper depends upon, spot diagnosis. So you do the X-ray and you decide this is type 1A, type 1-2, because this is not true. Look at the follow-up. This is patient with complete absent tibia at birth. Complete absent. Then, after 1 year, proximal enlargement. After 4 years, then almost you have the whole tibia. So if you diagnose the patient at birth, this will be a type. Then after 4 years, this is another type. So don't rush to the diagnosis. The problem again with the bilateral cases, you have to manage in a different way if you have bilateral cases. Because you have to have similarity both sides. The second problem with the classification, the patients treated before, like this patient. This patient was treated by synostosis and was scheduled for amputation. So when you want to diagnose the patient, which type? You have to, these are the difficulties of diagnosis. Again, the stability, very unstable ankle. And people try to classify the stability, but in my experience, it's very difficult. You can manage it case by case. Now type 1. Type 1, you have a complete tibia. This is complete tibia, which is very short. And this patient, we followed the patient up, and he was treated at the age 28. So when the people talk about tibial emilia and the age 1, 6 months or something, no. The story is different. So when we treated the patient by lengthening, you see here. It's more than 100% lengthening. And the people in some places in the West, they warn you against lengthening more than 20%. But we don't think that this is true. Again, this is type 2. You have absent distal tibia, only the distal tibia, like this patient, presenting at the age 4.5 years. And we do corticotomy here till we reach the ankle. And this is after removal. Again, and this is after 1 year follow-up. Type 3, the presence of the proximal tibia only, or more than 50% are lagging of the tibia. We do synostosis, then lengthening, and correction of the deformity, tenotomy, and the correction of the deformity. Type 4, we do an osteotomy here. This is the diastasis. And we do gradual correction using olive wire and screw traction devices. And at the same time, we do lengthening of the upper part. Type 5, we have diastasis of the tibia and fibula, see here. And this is the gradual treatment. And guided growth also because of the developing valgus deformity. Type 6, 60% of cases and 50% or more than 50% in the literature, complete absence of the tibia. This here. Coming at the age 5 years. The treatment strategy, I'm going to describe it in details. Why in details? Because this is the most common type. Our aim is to do knee centralization, foot centralization, correction of the knee. At the beginning in my publication, 2005, we did it stages, but now we do all of them one stage using the gradual treatment. These are the operative details. The ankle, we do tenotomy of the tendon Achilles. We don't do fibula shock. When we do tenotomy of the tendon Achilles, we don't correct the ankle acutely. If you want to correct it acutely, you have to resect part of the distal fibula. And if you resect part of the distal fibula, you are going to lose the physis. So we keep it as such. Just we do tenotomy of the tendon Achilles with no fibula shock. The knee. We do centralization. We do centralization in a different way. We don't expose the common pronator. I used to do that long time ago, according to the literature at that time. But the way I do it, you don't need to do common pronator release. We do an anterior longitudinal incision. We expose the patellar tendon. Then we mobilize the head of the fibula. We push the head of the fibula anteriorly and medially. And we make our incision medial to the head of the fibula. So the comma peroneal is on the lateral side. And then we expose the femoral condyles and the head of the fibula. And the head of the fibula subperiosteal. Then we position the fibular head between the femoral condyles of the distal femur. We don't have to correct the deformity. It's impossible to correct the deformity without resection of the head of the femur. And we never do this. We don't resect the bone. Bone is very precious. We need it for the length. Because in complete absence of the femur, it's very difficult to do lengthening. So if you want to avoid lengthening, you have to keep the fibula intact with the upper physis and lower physis. And this is my advice to you. It's very difficult. Whatever you do, you are going to face unstable ankle and unstable knee. So it's very difficult to do lengthening. So if you keep the physis of the upper fibula and the physis of the lower fibula, you are going to keep the length. Then you suture the patellar tendon to the head of the fibula. Then we apply the frame. It's all wire frame. We don't use half pins. It's all wires. We apply the frame to the distal femur and the upper tibia and the foot, the whole foot, calcaneus and forefoot. And we put 2K wires to keep the head of the fibula in the reduced position between the condyles in position. So we use transfixing wires. Why? To be sure that it is in the right position. Usually in the 90 degrees position, you can reduce the head. If you try to correct the deformity, you are going to lose the reduction. So we keep it in 90 degrees flexion, and we keep the head in position using 2 transfixing key wires. Then we close the wound after the application of the wires. And as I told you, we've applied the frame in the deformed position, 90 degrees flexion deformity, equino cavovarus deformity of the foot, and we keep it as such. We apply the frame without image intensifying. We don't need it. We don't need image intensifying. And this is the position you see here. Almost 90 degrees flexion deformity, equinovarus deformity of the foot, and rotation. Look to the rotation. It's all wire frame. Then gradual correction of the foot and ankle deformities. After 3 days, we leave this part in a flexible position for 6 weeks. Then we remove the transfixing wire. And we start gradual correction of the knee flexion deformity. Then gradual correction of the deformity after the removal of the transfixing wires, and the gradual correction of till we get overcorrection of the foot. During that, we repeat the X-rays over the knee to be sure that the head of the fibula is in the centralized position. If you have any displacement, we correct it in the outpatient clinic by changing the lengths. You see the correction, the X-rays, and the centralization. You see the position. You have to repeat the X-rays, and this is the foot correction. Then overcorrection. You see recurvatum, extension, deformity, overcorrection, and also overcorrection of the foot. Then under general anesthesia, we keep the patient in the reduced position for about 5 weeks. Then we remove the frame under general anesthesia. You see, we test the knee. You see, it's centralized, but still unstable. You see, this is the test of the knee. Again, the ankle also has instability, side to side instability. Now we do some derotation, because after this correction, you still have internal rotation deformity. So we do external rotation Then we apply wires. We apply wires in the ankle and wires in the knee to keep them in position, because now they are unstable. And it's very difficult to keep them in this position, even in a cast. Then we apply the wires for the knee and the ankle. Then we put the cast. We put the cast. And the cast is empty here, and the wires are apparent because we are going to remove them in the outpatient clinic without anesthesia. You see, this is the picture afterwards. You see the length. Again, my advice, if you keep the fibula intact without trimming the physis, you are not going to face limb length inequality. Now we put the patient in a cast and we remove, after 1.5 months, we remove the wires and we let the patient in a cast and walk in a cast. And then after 3 months, we remove the cast. You see the upper tibia, the upper fibula took the shape of the tibia. It's not stable, 100%. You still have some sort of instability. So we keep the patient in a brace for some time. This is what we do for type 1. Another example of type 1, because most of the cases are actually type 6. You see in this patient with bifid femur, again, we make all the stages, and we do gradual correction and centralization. And this is the picture. And this is the video sent to me by the family, because many families are living abroad, not in Egypt. Again, limb length discrepancy. Remember, most of them, the people, they have a problem with limb length discrepancy. And this is the real trick. Keep the fibula intact. Don't trim any part of the fibula for the sake of reduction. All of the literature, they talk about how to remove part of the fibula and to correct it and so on. So if you keep it, you are not going to face limb length inequality. Again, from the tips and tricks, like this patient who had been treated before, and this diastasis, we push the head of the fibula down by thumb. You see my thumb. And then use olive wires to close the gap down there. Again, we need to do corticotomy. It's very difficult in type 2 to do corticotomy, very small spaces you see here. So we apply the frame to the proximal, and we put a wire, and then we start the corticotomy before application of the distal frame. And I will show you the video clip. The middle level is too small. If you want to do corticotomy, we prefer to start the corticotomy after we put the wire, which is representative to the middle segment. And then we start the corticotomy by making a small incision, because you have very small distance. So we'll do most of the corticotomy by doing multiple drill holes. Then we dissect the preosteal on both sides. Then we put the whole liver on one side only, and just a triangle on the other side. Don't put the whole livers on both sides, otherwise you are going to make the incision longer. Then we do multiple drill holes. Okay. Right on the left on the bottom, anterior, and perhaps an anteromedial. Transverse of the bottom. Then we move the one lever to the other side to minimize the section. Start the drill hole. Now we give the wound, we cover it. When we apply the second ring or the middle ring, it's an open ring now. Give it to me. Put the ring here. And we mount the wire to the ring. And after the application of the middle ring, we are going to complete the osteotomy in this limb. Again, this is, you have the whole tibia, and we do centralization using, or synostosis using olive wires, and differential lengthening between the tibia and the fibula. Complications, tract infection, knee flexion deformity, and fractures related to the procedures, like fracture of the fibula, we applied wires here. Knee subluxation, knee stiffness. In conclusion, we cannot say amputation versus limb salvage because we don't have this choice. All the cases has to be treated by limb salvage. But about the evidence-based medicine, we have to think about case by case because it's very difficult to gain anything from the literature regarding the evidence-based medicine and the surgeon experience. Why on earth, when we talk about arthroplasty or other things, they talk to us about the volume of the surgeon. But when we talk about congenital deformities, the people try to present their experience with very few number of patients. The family choice, it's well-known choice here, no amputation. And your choice as a surgeon is reflected on the patients too. We presented recent simple classification of tibial hernia. I think this is an easy way of classification of tibial hernia. The limb preservation option we offer is again simple. We are less than average surgeons. We apply, we present simple solutions. We do many cases, lots of cases with simple solutions. Limb reconstruction is possible based upon the low tension stress. Again, this is the new classification. Type 1, complete short tibia. Type 2, absent distal tibia. Type 3, absent more than 50% of the distal tibia. Type 4, diastasis of the distal or the ankle. Type 5, diastasis of the whole tibia and fibula. Type 6, most common, 60% of patients, complete absence of the tibia. These are some references if you are interested. Thank you.
Thank you, sir. Thanks for your wonderful talk. We are always fascinated by the talks of yours. Now I hand over to Dr. Milind for his...
Wonderful. Professor Gamal, thank you for your...
Thanks, madam.
Your new classification is a little easy to understand. And my question to you, in the commonest type, you said the type 6, which has complete absence of the tibia. The message is, you have conveyed it very nicely, that do not resect the fibula, make use of both the upper and the lower growth plates so that length discrepancy is minimized. In the long run, other than bracing, how can we keep them stable in the very long run? Do your patients need bracing forever at the level of the ankle and the knee? Or is there any other final or better solution that you have now devised?
Most of the cases, they need some sort of bracing. Because, even in the cases with which were considered in the literature as stable, describe it if you have side-to-side, instability less than 10 degrees or something. But, in my experience, all the cases, they have some sort of instability. And all of them will need some sort of support, which is different from one case to another case. It can be, bracing all the time, can be mobile bracing with joints and something like this. Can be bracing just during walking, but at home, no, without bracing. But bracing is essential in all the cases.
I have done a case more than 30 years ago in which I fuse the fibula to the femur as well as the talus to the fibula. So there is no need for the child to walk with braces. As you pointed out, the difficulty with this was the reduced growth of the fibula, but it was overcome by leg lengthening in 3 stages later. But the stability allowed the child to walk without a brace for the rest of her life by the fibulofemoral fusion and the fibulotalar fusion. What do you think about this aspect?
Any movement is better than arthrodesis, you know.
Okay.
It's a good option if you offer them. But remember, you are doing arthrodesis of the ankle and the arthrodesis of the knee.
Yes, of course.
And the success of arthrodesis, if you do arthrodesis in one joint and you have the whole joints on both sides are normal, you know, there are rules for arthrodesis. But if you do arthrodesis for both of them, I don't think this is the right solution to do, except if you fail, if you have quite unstable knee and ankle, you can go to this solution, of arthrodesis. Besides, if you do an arthrodesis again, you are going to face limb length inequality, and you are going to, perhaps you need lengthening twice or something like this.
Correct. And what is your solution for the diastasis of the ankle? Do you reshape the distal end of the tibia, which is a little shorter?
The diastasis is easy to treat, but this is not the problem.
Okay.
The problem is the size of the talus.
Okay.
With the cases of the diastasis, the size of the talus is big.
Okay.
So if you correct it 100%, it's not going to fit the talus.
Okay.
So what I'm doing now, I do osteotomy and to correct it, but I don't correct it 100%. It's easy to correct it 100%.
Okay.
If you have a screw traction, you put multiple olive wires and screw traction devices, there's no point at all. You can, at the end, even you can put wires and you create synostosis in between or something. But you are going to face painful ankle because the talus is bigger. When you open it, you find it bigger than normal. So when we correct the diastasis, you don't correct it 100%. You have to correct it according to the size of the talus.
Great. That's a good thing to remember. And in the cases where you have an absence of the more than 50% of the tibia and the small upper tibia is jutting out through its own skin pouch, in that sort of case, do you also transfer the lower fibula to the tibia to try
Yes. And we do differential lengthening afterwards. Sometimes, in many cases, the head of the fibula is high up, and we do differential lengthening. We do corticotomy of the tibia, then we get it down, then we fix the head of the fibula to the tibia, then we corticotomy of the fibula, and we go down and so on. And this is the case I presented in the tips and tricks with a follow-up about 18 years.
All right. Great. That's a fantastic talk. Good to remember.
Okay, sir.
Here's Dr. Bari.
Professor Gamal.
Gamal Husni.
Yes.
Assalamu alaikum.
Seeing you after a long time, so you are looking more younger than your previous age. What is the secret behind this?
Very nice compliments.
Yeah.
You have to tell my wife that I'm looking younger.
Yeah. So actually I was seeing your grade 6 in which there was a complete loss of the tibia. So you have transferred the fibula, so gradually I think the fibula will become thicker and thicker.
Yes.
What do you think? Yeah. What do you think? Gradually it becomes thicker.
It's not gradual 100% because I do centralization the way I do it as I've told you, and also I do tenotomy of the tendon Achilles.
Yeah.
So in the upper part, I don't do complete centralization.
Okay.
Because, I put it in more deformed position to keep the head of the fibula without any trimming, without touching it, and to keep it in between, the femoral condyles. Sometimes you don't have femoral condyles, but in the center of the lower femur. And then I put 2 wires to transfix and to put the frame, and we keep it in position for 6 weeks. And then after 6 weeks, we correct the deformity gradually. And during correction, you keep the centralization, and you adjust the centralization. You can do side to side, you do it, I know that. Side to side, you can do derotation or something to keep it in position.
Okay. So I want to ask, after some years, about 10-15 years, they need another surgery? After 10 to 15 years?
Oh, in these cases, yes, yes.
Yeah.
Definitely. Especially we have complications, some complications like dislocation. I've talking about that. You have to correct the deformity again because
Yeah, yeah.
you cannot stop the deformity from recurrence. We do overcorrection. But after 4 or 5 or 6 years, you have development of flexion deformity of the knee because of many reasons, because of the soft tissue, because the shape of the articular surfaces are not, the shape is not normal. You have many factors inviting for the recurrence of the deformity, and we correct the deformity again, but it's far easier than the first operation.
Thank you.
Thank you. Gamal, you
Yes.
know there is in Kurgan, Professor Shevtsov has written 2 books that is in Russian language. And since I know the Russian language, the technique that you have done, they have elaborately written their books. One is fibular hemimelia, another is tibial hemimelia, written in Russian language. The centralization that you have showed, the head of the fibula, bringing it down, and you make a hole in between the 2 condyles of the femur and go for the synostosis. That you have shown. That is correct way.
No synostosis.
No, you are doing a hole in between the middle of the femur.
No holes. If you do holes, it's going to unite.
They are doing like that and making hole, and without hole you can make it centralization, and after that you fix with all the wires with Elizarov frame. Yes,
I know this.
This is I'm talking about your classification number 6, which is very common, and 1, 2, 3, 4, 5 is not so common.
Yeah,
Last
it's
one,
not, yes,
without
yes.
tibia, only fibula. That is the correct way that, and you have to go for re-lengthening 2 times or 3 times. And centralization of the ankle is also needed for that case. So these are the difficult cases. You don't need to go for any kinds of amputation. And we have never done the amputation.
We don't discuss the amputation because, it's not an option in our culture.
Yes, same. Okay.
Professor.
And the people, they asked me, why don't you offer them? Because I told them, because I'm one of those people. I have the same ideas. I have the same mentality. If he was my child, I wouldn't do an amputation. I'm one of them. It's very simple.
Do something, so you should have to do something.
Good evening, Kamal. I'm Dr. Zunzunwala from Bombay. Very nice. Your lecture was wonderful and fantastic.
Thank you, Dr. Junjunwala.
I have no case which I have treated because I did get any hemimelia case up till now. So I did not treat. But anyway, your classification and treatment is wonderful. Congratulations.
Thank you, Professor Junjunwala. I've learned a lot from Professor Junjunwala. We are friends for such a long, long time.
Professor, in your classification, I think number 2 and number 4, both are same type. Number 2 and number 4.
Number 2 and number 3, perhaps the same type, and both of them, you don't have the distal tibia.
Only diastasis is more. Otherwise, 2 and 4 are same.
Yes, this is only diastasis of the distal part, the second diastasis of the proximal and distal part, both of them. So they are far apart from each other, the tibia and the fibula. Anyhow, this type is about, I think it's about 0.9% of cases, and the other one we have only 1 case, so it's not that important. I discuss them just for discussion.
Okay, thank you.
But what's more important is type 6, followed by type 2 and 3.
Thank you, sir. Thanks a lot. And once again, we are very thankful from Assam, India, that you spared your precious time and gave us a good, very insight about this development.
Thank you very much. Thank you, Rajat, for allowing me to talk to my friends. I miss all of them.
Thank you, sir. Thank you. Now we have next a talk by Professor Reggie Hamdi from Canada.
Good morning or good afternoon. And I'm Rich Hamdi from Montreal, Canada. And this talk will be on the fixator-assisted acute correction. It's a very simple course, nothing like the complicated before me by Gamal Hosni or by Rosebrook. So you can relax a bit. Greetings from Montreal, that's the hospital where I'm working. And I would like again to thank Mr. Chairman, Professor Agarwal, Dr. Agarwal, and all the organizing committee. It's a real pleasure and it's a real privilege. You hear me well? Do you hear me?
Yes, sir.
Okay. I have no disclosure. The objective of this talk really, it's describe in some detail the fixator-assisted technique, which is not a new technique. I'm going to come to this, but essentially I will emphasize some few points because we are using this technique more and more. How to go from such a severe genovalgum to a thing like this, and to show that it's a safe, effective, quick technique using no complex frame, no complex software, no complex planning. As I said, it's a very simple, almost straightforward technique. So this technique is not new, has been described for more than 10 years by all these people. It can be used to treat many angular deformity, coronal, sagittal, and rotational deformity. And as we all know, it combines the advantages of both the versatility of external fixator and the internal fixation, using most of the time monolateral plates. And why we are using it more and more is simply because the advent of the locking plates, which allows us to use this. So the option that we have in the management of such cases, it's growth modulation in the skeletally immature. However, we all know that such a severe degree of genovalgum, growth modulation with a plate usually will not work. The standard method using standard compression, which up till now we used to have, or the fixator-assisted correction using lock plates, which I'm going to talk a bit about it. Nails, you can use it, but you cannot use it in skeletally immature because of the growth plate. And we have the new kid on the scene, which is the patient-specific 3D printing cutting edge, which is just appearing now, but I'm not going to talk about this. Even in our country, it's too much expensive. So I'll go quickly. How do I approach to a child like this? This is a 12-year-old boy from metaphyseal dysplasia, as you can see here from the X-ray, severe genovalgum, symptomatic. He has a subluxating patella and pain, and he had a failed hemiepiphysiodesis before. So you do your standard deformity analysis, examining is it an isolated genovalgum or not, soft tissue compacture, and after this, is it a uniplanar or multiplanar deformity. So that's all the basic deformity correction, the mechanical axis, and I will just emphasize few points in this. Mechanical axis deviation, we measure it in centimeters and not in zones, as the zone 1, 2, 3, it's really hard to reproduce between persons. So it's in centimeters, and then the standard angle, it's the lateral mechanical distal femoral angle. In such a case, it was 60 degrees. And that's the sagittal plane. It's posterior distal femoral angle. It's almost normal. The normal is about 83. Then where is the cora? In many cases, we have a two cora. Do we have to treat both coras? No. The first one is here. The distal one is really the one that we are going to treat, which is the intersection of the green and the yellow line. And most of the time, this very severe genovalgum deformity, the cora is almost at the gross plate, which complicates things. Why is it important to the Torah? Because simply it will tell us how much translation we have to do where we put our osteotomy. So if we put the osteotomy here, then there is no translation that we have to do, except that we cannot do the osteotomy here. If we do it here at that level, that will be among the translation that we do. If we do it higher up, that's the amount of translation. So we have to find the minimum bone that we have to keep proximal to the gross plate so that we can put the screws of the plate. In the pre-operative planning, we finished with this. Then we have to decide all these things: closing versus opening, the choice of the locking plate, external fixator, where we put it, shortening of the femur. That's another point that I would like to emphasize. Almost all the severe genovalgum that I'm doing here, or we are doing, we do a shortening of the femur. And I'll just talk a bit about the patellar maltracting. Closing wedge or lateral wedge, the literature is full of articles. I just want to mention one thing here. In a very late article appeared just a few months ago in a systematic review and meta-analysis, there is no difference between a closing wedge or an opening wedge in the treatment of severe genovalgum. I prefer the closing wedge because it's a bone-to-bone contact. Choice of the fixator, we use a very simple external fixator used in trauma. We don't have to use a complex hexapod or a complex monolateral. A very simple 1/2 pin, 1/2 pin, and a distraction rod. However, ideally, you should put the angle between the two pins. It's the angle that you want to do your correction, so that at the end of the correction, the two half pins are almost parallel to each other. Then we come to the choice of the locking plate. The only thing here is that the distal part has to be resolved like this, triangular, so that it can fit on the metaphysis. And I use locking screws proximally and distally. And we put it first to decide where you will do the osteotomy, so that you can decide after this how much space you have for putting the screws. Patellar maltracking, I'm not going to go through this. Again, it's full of controversies in the literature. Some do an osteotomy only with nothing regarding the patella. Some do soft tissue procedure like a lateral release in DMO and the medial capsular reefing. Some repair the medial patellar ligament, and some do a bony procedure. So it depends what you decide. My advice, we always consult a sports medicine colleague, and if it's for me, all the time I do a lateral release medial capsular reefing. But again, take the opinion of a sports medicine guy. Where to apply the temporary external fixator? I think you can apply it anywhere that you feel comfortable. You don't have to put it medially, you don't have to put it anteriorly, and usually what I do here is that I bypass where I have to put the plate. It's the easiest and the most comfortable for me. But essentially you can put it anywhere that you would like. That's a very quick video here. It will take 1 minute, and try to have this. I have to have this on a 3D for severe deformity. This is the 2 half pin. That's the gross plate, which is just distally. You have your fixator on, and then using first you put the plate to check the position of the plate, and then accordingly you will do your distal osteotomy. And as I said, always do a femoral shortening in these severe genovalgum, and then you remove this wedge of bone, and you do your correction after this of the angulation. You can see here, and then it will be the correction of the translation, and that's the amount of translation that you have to do until these 2 lines go in lines. You remove this part of the wedge of bone, and then you put your locking plate in. So you have done all the planning beforehand. In cases like this, especially skeletal dysplasia, I always do an upprogram. That will give me more details about where the articular cartilage is so that you calculate your angles. You can do a CT, you can do a 3D reconstruction, but the most valuable is the intraoperative upprogram. And then have your intraoperative planning here, the positioning of the patient, the soft tissue releases, all of them need a common peroneal nerve. As a rule, any correction of a valgus deformity, we need a common peroneal nerve release. Application of the fixator, then the femoral shortening, and the wedge osteotomy, and then the realignment of the patella. That's the position of the patient, whether you use a bone form or simply towels, that's up to you. Common peroneal relief, it's a must, and you should see one of these two videos. I recommend the video. It's on the internet by Susan McKinnon. It's a 10-minute video. It's a superb demonstration of the 3 facial layers that you have to cut to completely release the common peroneal nerve. And you can see it here. That's the common peroneal nerve release. Then you apply your fixator. So in yellow, it's the half pins. This is the 2 K-wires to tell you exactly where the osteotomy. And I put 2 other K-wires to control the rotation. And that's the side view. So here we have the 2 K-wires for the osteotomy. You can see the cuts here. And that's the bone that has been cut with the shortening. And then you use your external fixator as a sort of joystick to obtain your correction. In fact, if you do these cases, even you don't need an assistant. Your assistant is the external fixator. So we can see on the upper left, that's the wedge of bone that you can remove it, and then the application of the locking plate, and I use locking screws everywhere, distally and proximally. There was some concern regarding the accuracy of the reduction for a fixator assisted, and the accuracy is similar to other techniques. And you can adjust intraoperatively. You use the anatomic axis, which is the most easily because you don't need to go to the hip or the ankle. However, you can use also the Bovie line for this. And that's your surgical correction, and that's the post-op correction. That's your mechanical access from head to the center, and that's if you use the anatomical axis. That's before the surgery and after the surgery. Patellar malalignment, I say I'm not going to go through this. The 2 complications that most common, it's the accuracy, so you need an intraoperative confirmation, and we have to remove the plate as soon as there is healing because it's a cause of concern. That's, as I said, you can use this technique anywhere in the femur or in the tibia. Compared to the fixator-assisted nailing, it's the same outcome. If you can use it, you can use it in adults, but in skeletally immature, it has to be the fixator-assisted team. And my last slide here, it's a very safe technique. You don't need anything complex. The planning and deformity is crucial. Always consider any valgus, a common peroneal nerve release, and the femoral shortening. And we mentioned the intraoperative confirmation and early removal of the plate as soon as possible. Thank you for your attention. And thank you again for asking me to talk.
Thank you, sir. Thank you, sir, for the great talk. And we are really thankful to you that you spared your time and you joined us in this annual conference of Asam India. Now I hand over to Dr. Milind.
Hi, Reggie. Thank you very much for this simple and elegant talk. We all of us appreciated it.
Thank you, Milind.
There are so many ways which have been described to fix genu-valgum correction. Your technique is indeed simple. It relies on a little bit of shortening. But in case you were to perform the focal dome osteotomy or even this osteotomy with the lateral translation, do you think it's a little easier to put in a locking plate on the medial side? You think which will fit better without having to resect that excessive bone?
I completely agree with you whether to do femoral shortening or not.
Okay.
In cases of bilateral, like most the severe genovital, we find them in skeletal dysplasia, so it's bilateral. So I have no really concern about the femoral shortening. A dome osteotomy, yes, you can do it. I do it very rarely. It's always difficult, at least for me, to do a dome, like a typical dome osteotomy. However, for the locking plate, I mean, the locking plate for many, it was one of the greatest inventions of orthopedics, because you can put it anywhere. You don't need this bone to plate contact. And I don't look at how much distance the plate is from the screw.
Right.
So I don't have any problem putting locking the plate. As I said, if you feel comfortable and you have the necessary instruments to do the dome osteotomy, for sure it's a very good alternative. It could be an alternative to the femoral shortening.
Great, thank you.
Excuse me, please. Excuse me. May I have a question? Yeah, it's possible.
Sorry.
Yes.
Hello. 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 It's Leonid Solomin. Hello, everybody. May I have a question, please?
Yes.
Yes. The question regarding your technique. As far as I understood, the first half pin you are inserting to the diaphragm, perpendicular to anatomical axis. Yeah. Yeah. The second half pins are you inserting parallel to the joint line. But first half pin, anatomical axis. Joint line parallel, mechanical axis. That's why you are combining first half pin relative anatomical, second mechanical. How it is possible? Or are you mistaken?
No, you are not mistaken. And that's if I go back, if you, the proximal pin is perpendicular to anatomical axis, yes, because it's difficult to go along the mechanical. You can go the mechanical. The final correction will do it anatomical, okay? Like the cut really doesn't matter, even if it's not a bone-to-bony contact. The final correction, you draw a line and it's in front of you, so you can calculate the anatomical axis clearly distally. Like you can make it so that it's 82 degrees or 88 degrees. And the alignment, as you can see, like if we share again the screen and we go at the end completely,
I think he's answering. What's the question?
okay? So that's at the end, but you can make your adjustment intraoperatively with the external fixator. So here we have the mechanical axis goes through the middle of the knee, and the anatomical axis that you can calculate also intraoperatively is 82. So it addresses both. That's the beauty of this technique. And at the end, even if there is a 2 or 3 degrees that is outside, if you want the typical thing, I don't think it matters.
Great. Thank you so much, Reggie. That's wonderful.
Thank you, sir. Thank you for joining us. Now our next talk is by Professor Leonid Soleiman. I welcome you, sir. And
thank you very much
the
indeed. Thank you, Milen, for the question also.
Okay, let me share my screen. Okay, sorry. Okay. Pardon me, how to share my screen? Okay. Can you see my screen? No?
Yes, please go
Hello?
on. Хорошо.
Hello?
Yes, we can see your screen.
They can say full screen, yeah?
Yes, we can see it.
Oh, great, I'm happy. I miss India, my friend, and I'm extremely happy to be invited. Hope next time I will be alive, only my face on your screens. And according to request of organizing committee, we should dedicate our talk this terrible problem. Defects of proximal tibia accompanied with proximal tibia fractures. Terrible problem, it's very difficult problem. Or you expect from me a range of kind of defect. I think the second option. For this purpose, we should, I kindly ask you, make in our own integration with classifications, principles, and methods should be used in managing of bone defects. About classification. 4 years ago, our team, including Dr. Rothbrook, hi, and me, evaluated all classification we find all over the world in both literature. On these bases, we've developed universal long bone defect classification. Now it's under validation, and taking this chance, I kindly invite you to take part in this project. First of all, our classification is based, of course, on terminology and not police. The first term, bone defect, absence of viable bone. It can be dead bone, artificial bone, allograft, and in connection with previous report, atrophic, non-union, with avascularized ends, with dead ends of bone should be considered not like non-union. It's different. But about this point a little bit later. The next important key point, bone integrity. And there is detailed prescription, explanation in our classification, what's mean partially intact bone defect, cortical defect, detailed prescription how to measure length of defect, even we have oblique ends of bone fragment, and so on, so on, so on. What about structure? Our structure of our classification almost coincide with classification of AO, classification of fractures. The same numbers of upper, forearm, the same number of segment, proximal, diaphyseal, distal. But you know better than me, there are 3 types of classified by AO types of fractures, A, B, C. We had to involve type D, amputation, because amputation, agree with me, special kind of bone. How to use this classification? Very simple. Let's look at the screen. Amputation, no, okay. There is in bone integrity, yes. Type A, shortening, diastasis. Type C, very simple. Only one slide regarding principles of bone defect management. First point is sounds a little bit strange. There is a defect. But on the first stage, we should forget about bone defect. Because if we have no infection problems, when we have good soft tissue envelope, it's not a problem to treat bone defect. That's why this important point is the first one. The second point, to ensuring bone integrity first, we will discuss a little bit later. And finally, it can be, and a lot of us can see this picture, very good X-ray result. But unfortunately, unfunctional biological prosthesis. We should avoid this situation. So, what about base method we can use, we have the possibility to use in treatment of long bone defects? The first part of this method, graft-based. We can discuss 1, 2, 3 days. It's big problem, but having time frames, let me move from the discussion graft-based. Autografts, muscular technique, printing allograft, and so on, so on, so on. The second big part of method can be used in long bone defect treatment based on destruction osteogenesis. Huge part of treatment method, classical ELISAR, combined and consecutive use of external and internal fixation, internal destruction. And third part, prosthesis. I remember about type D of bone defect. So, on the bottom, on the basis of pyramid, are principles and classification. And for this basis, we should provide optimal choice for very this patient treatment. Let's try. Okay. Type A, the simplest kind of bone defect. Type group 1 and 3, so-called type A1 and type A3. So bone integrity preserved and there is cortical bone defect. Shortly, extremely short, I remember about time. Grafting. Which kind of grafting? It's special idea for special talk. But you hope you agree with me, the optimal method was this simple defect treatment, grafting. It's not strange for you. But on the basis of this classification, shortening and deformity are not all, should be considered not only like deformity parts, components of deformity. Shortening and deformity should be considered as defect as well. And simples only angulation was in our mind. Deformity correction according to Elizara, this correlation triangular regenerate. Defect, yes, defect. And after that, I am so sorry, and after that, we can change external fixation for internal one. Modern approach. What about a 2.2 defect? Shortening, simple shortening, speaking beforehand, huge number of very effective method of treatment of this kind of defect. Of course, first of all, method Elizar, including multifocal destruction osteogenesis. But lengthening of a nail, lengthening along the plate, lengthening then nailing, lengthening that plated, internal destructors, motorized nails, motorized plates, huge number of very effective methods for very this simple kind of defect. A 2.3, not only angulation, not only shortening, combination of angulation and shortening. Of course, Elizarov technique. This followed by internal fixation. Why not modern approach? Internal destructors. Why not acute angular deformity correction and then lengthening? Modern approach, almost mainstream. Type B. Interrupted bone integrity. And according, similar to the type I, we should provide where patient have cortical bone defect, grafting, but due to we have interrupted integrity, we should add internal fixation, plate, nail, external fixation, this point of special discussion. But very effective method for this particular case, proximal tibial non-union and large cortical bone defect. Spleen bone transport is much better for this particular case, provide result than in comparison with grafting. Type C, red. Type A, defect, no, maybe defect. Type B, interrupted, no, almost defect. But type C, segmental bone defect. Group Y, C1, full bone contact. 2, C2, limited bone contact. And C3, real bone defect. This diastase between bone fragments. And what about type C? There is specification where there are combination with diastasis and shocking. Type 3 have special specification. What's a prospective method, modern method for treatment of this kind of defect? Muscular technique, quite. Second picture, look precisely at this. Last 20 years, from time to time, I can see, together with you, of course, together with you, publication regarding cages, titanium, cages, biological, different kinds of cages with perfect result. Problem for the first view can be absolutely solved. Use a cage, forget about Elizarov, forget about muscular technique. For what reason should you use them? But unfortunately, it's not replicable method. Why? That's why we have to use till now, 2024, Elizarov technique, maybe with changing internal fixation. Bone transport over nail and along a plate. Motorized nail, conventional motorized nail, and specially designed motorized nails for bone transport. What about the more complex C3.3? Of course, for upper extremity, the more effective is vascularized bone grafting, accompanied with based on microsurgery. And back to similar picture. It's our dream, and I hope the nearest future we should forget about Elizarov technique, internal destructor, and the prosthesis of bone. But from year to year we can see picture, similar picture, but on my table I have no possibility to use this technique in my hospital. Unfortunately, I know about yours. That's why, again and again, great thanks to Elizarov, and we use for large segmental bone defects toward tandem technique of bone transport. For large tibial bone defect, till now, this method over 30 years ago was developed, but it's still effective. Fibula transport. And now let me take a small break. What about optimal method of treatment C3.2 bone defect? I remember the second point of principles of bone defect treatment management, ensuring bone trajectory first. From the first of view of this point, classical Elizarov method, bone transport, with simultaneous restoration of length of extremity is possible. But you know better than me, huge number of complications in stolon. That's why I couldn't say it should be forbidden. And in the hall, on the podium, around me, around you now, a lot of masters in this field who can provide bone transport 10, 20, 15, 20 centimeters. But for beginners like me, for example, can be better today to provide, to follow this principle. First step, for example, acute shortening, union, and we move type 3.2 to type A2, only shortening. And you remember, huge number of very effective methods to treat bone defect A2 type and less. The second way, okay. Not acute shortening, complete shortening and union. Let's do shortening, provide union on the docking site, place, and continue lengthening. Like this method is variation. Provide shortening with union, move C1 to A2 bone defect, and a second stage to provide lessing of this defect. Well, it's very simple clinical case. There is shortening 4 centimeters, diastole 6 centimeters, and we follow this principle. First step, bone transport over nail with rewind shortening 4 centimeters and move C3.3 defect to A2.2. And second step, using the same length, nail lancing over nail. Really, we prefer and kindly recommend you this way of C-type defect treatment. Extremely shortly, I am looking of my watches about articular defects. The same principle. Amputation, no. Articular surface involved, no. Type A, more than 50%. Type C. Very simple. What about simple defects? Grafting. More details discussion can be done in a special session, but we have time to do it now, unfortunately. What about C-type defects? Of course, endoprothesis. Of course, different time, individually printed, full, huge industry involved to solve this problem. But from time to time, azoplasty, deep infections, spacer, deep revision azoplasty, and finally we have defect, for example, proximal femur. There are contraindications for revision azoplasty. What should we do? Elizarov pelvic hypotostomy, developed over 30 years ago. Very good functional result. And we recommend it young and patient who have a desire to be involved in active life. What about large defect formed knee joint? Knee joint, large bone defect. The same principle. We avoid long bone transport. You see, first of all, acute shortening, and we forget about residual shortening. Union, and after that can be done any Elizarov technique. Standard Elizarov technique, cable-based Elizarov technique, and so on. Lancing over nail, bone transport over nail, very progressive. Why not? But look at this picture, is this quadrilateral gray? It's imagine direction of distal moved tibial bone fragment. There is curvature on long fusion nail and straight Elizarov threaded rods for destruction. And in minimum 4-5 centimeters, bone fragment should be out of this long fusion nail. What should we do? Very simple solution. We should provide for bone transport orthopedic hexapod. You see this picture. During calculation in software, hexapod software, we should provide at each step. It can be each 1 millimeters, each 2-5 millimeters. It depends on where is this case. Traction, angulation, translation. Traction, angulation, translation. Traction, angulation, translation. And at each step, nail will be exactly in the center of bone. 100% avoiding the jab. To provide perfect anatomical and functional result. One clinical case, dye study 40 centimeters, shortening 11, 25 centimeters bone deep. First stage, shortening and bone fragment union. Integrity preserved. After that, lancing or nail, and final step, we never offer patient where if they have shortening less than 5 centimeters, lancing of extremity. It's much easier to provide short. So residual shortening, residual limb length discrepancy 5 centimeters, it would be better to shorten contralateral lower leg like for this particular case. So, only 1 minute. It's out of few replacing reconstruction surgery, general. Of course, in continuation with previous Robert Rosebook report. Mainstream integrated exoparadigms. So, let's back our pyramid. Principles, classifications. It's so easy. For the first view, rest, but we are only top of pyramid, and we must consider influence a lot of factors. That's why we only let me repeat, on the top of iceberg. In conclusion, I have to say only that to be free in field of management of long bone defect, we should be 100% replacing reconstruction surgery, external fixation, internal fixation, lengthening of a nail, bone transport of a nail, a little bit prosthetic, a little bit reconstruction surgery. Use this classification. I kindly offer not masters, not my mentors, but beginners, let me repeat like me, use this AO principles-based classification of long bone defects. To simplify, make in order our knowledge of risk classifications, method, and treatments options. And finally, again, not to try provide a long bone transfer. It would be better to transfer C defect into B type, and then like in treatment of fractures. That's all, guys. Thank you very much. Best regards to all my Indian friends.
Thank you, sir. Thanks a lot for your excellent talk. And we are very delighted that you spare your time and be with us. I hand over to Professor Bari for the...
My dear friend, Solomon.
Cheers, Barry, friend of mine, cheers.
How are you? It was a very good talk.
I miss you, my friend, I miss you.
We also miss you. So, your message is, we must go from B to C, or B to A, C to B, and B to A. Okay?
Really, in our mind should be. We should avoid situation to treat really large segmental defect in one stage, in the main idea.
Yeah.
In what cases we should provide acute shortening to move C type to B type, yeah?
Yes.
And A type. It's points for special discussion. Unfortunately, we have only 20 minutes, but you absolutely understood, absolutely correct. Absolutely correct. But option from C to B, from B to C, or directly from C to A, it's special talk for each particular case.
Thank you very much for beautiful lecture. Okay.
Especially for you, my friend Vali.
Thank you.
Thank you, my friend. Thank you.
Thank you.
Thank you, sir. Thank you once again. Yeah. Thank you, sir. Thank you.
Thank you. Thank you so much. Thank you.
So with this,
thank you very much for the invitation again.
Yeah. Thank you, sir. Thank you. Thank you. So with this, we came to the end of this virtual session with all the famous stalwarts all over the world. And I thank you all. And we will have a quick GBM after this. And I invite you all for the gala dinner at 8 p.m. It will be here in this hall only. The drinks and snacks, DJ and the Russian performances will be in the hall. And in the front lawn
Peter,
will be the
drinks
dinner.
and snacks, it's allowed not for us.
We'll see you. Bye-bye.
Have a good evening. Have a good drink and snacks. Bye, my friends. Bye.
Bye-bye all together.
Thank you.
Bye. Bye.
Yeah. So we'll start GBM shortly. Thank you.